Well, hello, everyone. My name is Heidi Christensen, and I'm with the Center for Faith-Based and Neighborhood Partnerships at the U.S. Department of Health and Human Services. And we are so very glad that you have joined us today for this third in a series of webinars focused on the opioid epidemic, strengthening your community's capacity to connect to vital services and support. With our special guest presenters, Monty Burks, who directs the FaithBased Initiative for the Tennessee Department of Mental Health and Substance Abuse Services, and Kevin Hoffman, president of the Three Oaks Center in Dayton and the Congregational Care pastor at the Vineyard Church in Beaver Creek, Ohio. And I'll introduce them more in a moment. But together, they will share with us how faith and community-based leaders are joining their compassion and their missions with proven expertise that's bringing hope and healing to their communities. The Partnership Center here at HHS works to support faith and community leaders by sharing timely information and models of community-based practice and resources that we hope will strengthen their response to the public health initiatives and public health crises such as the opioid epidemic very much in our midst. With that mission in mind, our 2018 webinar series features community leaders talking about the innovative and promising practices they are implementing across the country in response to the opioid crisis and the need to support those struggling with substance use disorders. Our conversation today will focus on how faith communities are getting the training they need to build their capacity to initiate early interventions, provide ongoing recovery support, and even make referrals to treatment. Now, building community capacity is one of the 6 different strategies outlined in the Partnership Center's Opioid Epidemic Practical Toolkit. And we have uploaded the newly revised version onto this webinar platform. And if you look to the right of your screen and you click on Handouts, that tab, you will be able to download the newly revised toolkit during today's webinar. And if for some reason you are streaming this webinar at a later date through the recording, you can email us at partnerships@hhs.gov and we will send you a copy. So we have an exciting and hopeful conversation to look forward to today, but first a few housekeeping notes before we begin. This is an educational webinar, off the record and not intended for press purposes. So if you are a member of the press, we will be happy to connect you to the press office here at HHS after the program. While we do have a full program today, we welcome your questions and comments throughout the webinar. And we hope to share as many as possible with our presenters during the brief Q&A at the end of the program. Also, and this is always good to note, if you are having difficulty with your audio, you may find it helpful to call into the number on your screen, which is also in that panel up in the second quadrant down there. Rather than listen through your computer, we have found that sometimes that just works better for sound quality. So give it a try if you're having a problem. And as a final note, we will be sending a link to the recording of today's webinar in a follow-up email to everyone who has registered for the webinar. So let's begin. On average, 115 Americans die every day from an opioid overdose. In 2016, over 11 million Americans misused prescription opioids. Nearly 1 million used heroin, and 2.1 million had an opioid use disorder due to prescription opioids or heroin. Too many of our friends, family, and community members are being lost to this epidemic. But while it can easily look like a downward spiral, communities are responding with hopeful and promising practices that are merging the science of public health with the compassion, strength, and reach of their communities to save lives, connect people to treatment and recovery programs, support folks on the long road to recovery, and even protect future generations from harm with preventive efforts that are building the resilience of younger generations. The Center's practical toolkit was inspired and informed by these wise and experienced practitioners, and today we will hear from 2 of them as we explore how to increase the capacity and expertise of those working directly with community members and or their families suffering with substance use disorders and their too often severe consequences. We'll also learn how to build on the wisdom and experience of those already in recovery to connect folks to essential community support and to other vital services. I am delighted and privileged to introduce our presenters today. Kevin Hoffman is the president of Three Oaks Center, a nonprofit organization in Dayton, Ohio, that provides early intervention services to adults with alcohol and drug issues, pastoral counseling, as well as consulting and training services. Kevin is also an ordained pastor, serving several pastoral roles in Iowa, Minnesota, and presently as the congregational care pastor at the Vineyard Church in Beaver Creek, Ohio. He brings to these vocations an extensive background over the last 20 years in chemical dependency, mental health, and the social service fields. Kevin will be followed by Monty Burks, who is the Director of Faith-Based Initiatives for the Tennessee Department of Mental Health and Substance Abuse Services, where he builds the capacity of Tennessee's faith communities to help expand addiction recovery support services across the state. He also oversees the Tennessee Lifeline Peer Project, a state program we'll hear much more about later in the presentation, that is aimed at reducing the prejudice associated with people who suffer from addiction. Monty also brings an extensive background in criminal justice to this work, as well as a doctorate in theology. Kevin and Monty, we are so very grateful to you both for your willingness to be with us today, and we are eager to learn how communities can strengthen their response to those in their neighborhoods and communities who need them the most. And Dr. Hoffman, we're going to turn that open mic to you.
Well, thank you, Heidi, for your gracious introduction. I appreciate that so much. I'm so glad to be able to be with you all today on this webinar. And I want to say that today I'll be sharing from my Judeo-Christian faith tradition. However, the information that I'll be sharing can be applied to many other faith traditions. My story starts out, first of all, with this. From the New Testament of the Bible, in Galatians 5:1, it says, "So Christ has truly set us free. By God's grace, on April 3rd of 2017, I celebrated 45 years in recovery from alcohol and drug abuse. By God's miraculous power, I'm a suicide survivor and Christ follower. My family that I grew up in included alcoholism. And at the age of 8 years old, I found the stash of alcohol and began using. By the time I was 12, I was drunk nearly every weekend. And from 12 to 14, a friend introduced me to marijuana and later to hashish oil, amphetamines, barbiturates, and my life was a train wreck waiting to happen. Attempted suicide at 14. And in the midst of that, God intervened and rescued me, and my solid commitment to a personal faith ensued. Also in Galatians 5, it says this, "For you have been called to live in freedom. Use your freedom to serve one another in love." As a great prophet Bob Dylan once said, "You gotta serve somebody." And because of God's compassion and his love and mercy through the power of his Spirit, I dedicated my life to serving Christ by serving other people. I first got started in Alcoholics Anonymous and Narcotics Anonymous. One of my very first sponsors was a Jewish rabbi. He taught me the importance of giving back, contained in the 12th step of AA. He invited me to assist him in the establishment of a suicide hotline for teens in my community, which we did. About a year and a half later, another pastor came and asked for some assistance with the establishment of a group home in our community to help troubled teens as an alternative to incarceration at the boys' reformatory or girls' reformatory or the state mental institutions. And I'm happy to report that that group home is still going today. At 18, the juvenile probation officer invited me to become a probation officer aide to assist troubled teens as well. And ever since then, I have been involved in this crusade, if you will, to help folks who struggle with substance abuse just like I did. So my story professionally is I became a clinical social worker in the state of Minnesota, and I worked there for nearly 15 years. Moving to Ohio 15 years ago, became a chemical dependency counselor a few years back, and through our nonprofit that we have called Three Oaks Center, created a faith-based early intervention program that was the core of my doctoral dissertation. I became a member of the Community Overdose Action Team, or COAT, which is part of the prevention branch of the Alcohol, Drug, and Mental Health Services, or ADAMHS Board of Montgomery County here in Ohio. For those of you who might not be familiar with what's happened in Dayton in the last year or so, take a look at this headline from June 9th of 2017 from NBC News. Mass casualty event. Ohio County now tops the U.S. in overdose deaths. As you can see in the quote from our Sheriff, Phil Plummer, we received this ignoble title of being the overdose capital of America. Not something that we are proud of. Our senior pastor here at the Vineyard, Doug Rowe, he called our church to 30 days of prayer, based on the scripture in Isaiah that no weapon that is formed against you will be able to prosper. And so at the end of that 30 days, he invited me to create a call to action, steps that were very practical that we could engage in as a faith community. So we partnered with a community-based organization offering Project Dawn. Dawn stands for Deaths Avoided with Naloxone. This organization trained our entire church staff in overdose education and the use of Narcan. We also partnered with a community-based organization who trained our church staff in mental health first aid, both youth and adults. Again, that was the ADAMHS Board of Montgomery County. We partnered with yet another community organization to work with them in hosting an equipping conference at our church. We partnered with the Goodwill Easter Seal Society of Miami Valley to train one of our staff pastors in Generation RX, educational resources to help prevent the misuse of prescription medications across the lifespan. And we partnered again with the ADAMHS Board of Montgomery County to train several of our staff pastors in the use of building prevention with faith, a faith-based substance abuse prevention toolkit that's published by Prevention First out of Cincinnati, Ohio. If you see in this slide, we saw some remarkable results happening in our community. In May of 2017, 81 overdose deaths from opiates. But as you look through June through December, you see a decline. Our hope is that the combined efforts of many churches and organizations in the community, law enforcement, government, the medical community, treatment providers, prayer, according to the Montgomery County Coroner's Office, we saw a 78% decrease in accidental overdose deaths between May and December. And we want to believe that we were able to contribute to that by all working together in our respective ways. If we think for a moment about a working definition of addiction, according to Catherine Van Wormer and Diane Ray Davis in their seminal work, Addiction Treatment, A Strengths Perspective, addiction is, and I quote, a biopsychosocial spiritual phenomenon, end of quote. The word addiction comes from the Latin word addictus, which means to be attached to something. Today, addiction has been called a brain disease, a bad habit, even sin. Our leading assumption is that addiction is the key, not the actual substance or behavior. Addiction has been defined or described by researchers as a bad habit, a brain disease, helplessness, a problem of motivation. Historically referred to as an individual problem, a family problem, a societal problem, a criminal justice problem, a moral problem. In the DSM-5, for those of you who are not sure what that designation is, it says in the bottom of the screen, It's the Diagnostic and Statistical Manual of Mental Disorders, 5th edition, published by the American Psychiatric Association. Changes to the DSM in the new edition no longer have this dichotomy between abuse and dependence. Addiction is now the preferred term instead of dependence. Addiction is now viewed as a public health problem. Addiction can be seen on a continuum. At the lower end of the continuum, abstinence or low risk, representing about 75% of our general population, where no intervention or screening or feedback is needed. However, there's this area of hazardous use and harmful use that makes up, or excessive use, if you will, makes up about 20% of our population. And that's where brief intervention, and screening and brief intervention and treatment is needed. Only about 5% of our general population represents those who struggle with a substance use disorder, where brief intervention and referral for additional services are needed. The bulk of the costs, both personal and healthcare and societal, are not the result of substance use disorders, but rather of excessive use. So recapping, addiction then is a pattern of compulsive use. It has physical, psychological, social, and spiritual aspects. And the emphasis is on process rather than outcome. So as we look at a biopsychosocial spiritual model, we can look at the why, or in other words, the biological piece. An exploration of recent developments in neurobiological and pharmaceutical research related to addictive behavior helps us to understand some of the biological factors that are at play. The what, or in other words, the psychological considerations, where we look at motivational and cognitive-based treatment innovations and evidence-based research on treatment effectiveness. And the where, the sociological piece, the realization that any specific individual who enters into treatment does not live in a vacuum. That individual is both shaped by and is a shaper of his or her social and political environment. And of course, the need for spiritual healing, that sense of the meaning and the purpose of life. How do I fit into the grand scheme of things? Including in this is a vibrant religious faith that can be drawn upon a connection with a very personal higher power. We think about interactionism and the cycle of pain, the cycle of addiction, as it's often referred to as. People experience pain and suffering. They experience loss and then more pain, more stress, drinking and drug use, and then more pain. And this becomes a vicious cycle that people go round and round, unable often to escape. The family needs to be understood as a system in interaction with those individuals. We are grateful for the work of Claudia Black and Sharon Wegscheider-Cruz and Virginia Satir, understanding the roles in a family, traditionally as enabler and hero and scapegoat and mascot and lost child, the roles that are a part of so often what we see happening in families. Because it's not just the individual with the addiction that needs assistance, it's the entire family that needs help. Having just a momentary difficulty with the slide here. Hang on just a second. When we think about continuum of care, let me speak just briefly about prevention. We know that in prevention, we must decrease risk factors and at the same time, increase protective factors. When I talk about decreasing risk factors, we want to look at those risk factors which can increase a person's chances for drug abuse, while also increasing the protective factors that can reduce that risk. For example, early childhood risks, such as aggressive behavior, can be changed or prevented with family, school, and community interventions that focus on helping children develop appropriate positive behaviors. When we consider mutual health groups, of course, one of the oldest in this genre is Alcoholics Anonymous. and Al-Anon. There's lots of anonymous groups that are out there. Nearly every substance has an anonymous group: cocaine, heroin, crystal meth, marijuana, nicotine, narcotics, pills anonymous. There are prolific numbers of anonymous kinds of groups in our culture and society. Of course, JACS, which stands for the Jewish Alcoholics, Chemically Dependent Persons, and Significant Others, is another group. Generic Steps for Change, Rational Recovery, other groups like Smart Recovery, Women for Sobriety, Secular Organizations for Sobriety, and Celebrate Recovery, which personally I've been a part of for over 22 years, which emphasizes freedom from whatever our hurts, our hang-ups, and our habits are. And of course, Living Free is another great example of a mutual help group. In terms of early intervention, we have some great diversion programs that are available. Here in Ohio, we have driver intervention programs that people can go through in lieu of jail time, a weekend intervention kind of program, which is what the early intervention program, our faith-based program, is patterned after. And then there's SBIRT, which is screening, brief intervention, and referral to treatment, which I'm going to come back to in just a moment. And of course, treatment. Detox is often needed outpatient, traditional outpatient, or intensive outpatient, inpatient treatment, residential, both long-term and short-term. One of the best examples is Teen Challenge, which also works with not only teens, but also adults. That depending on which substance we talk about, has an 86 to 92% recovery rate based on 3 different studies that were done. The first one was the Department of Public Welfare back in 1972, and 2 other universities cite the quote-unquote Jesus factor, or faith in other words, as the primary reason for the success that people have experienced. When we think about SBIRT as an individual who is in recovery, coming from a family in recovery, as a pastor, as a professional trained in counseling, whenever an individual is in crisis and substance use is involved, if it's a marriage and family issue, one of the very first places they go is to see their pastor or faith community leader. If it is a medical or a physical issue, they go and see a primary care physician or an urgent care center or an emergency department in a hospital. If it's a legal issue, we see them perhaps in the court system somewhere. SBIRT was developed not to identify those who have substance use disorder and need higher levels of care, but it was developed to help to identify those who are at moderate or high risk for psychosocial or healthcare problems related to their substance use choices. So what is SBIRT practice? SBIRT consists of 3 evidence-based practices for identifying unhealthy substance use risk behaviors by conducting a screening, and that screening is an important part of that first part of the process, by addressing risk by conducting a brief intervention, and or referring to treatment for further assessment. If we break down the moving parts that are part of SBIRT, pre-screening is universal. In other words, for everyone. I've been working here in Ohio, training primary care physicians' offices and emergency departments and hospitals, medical students, and screening everyone who is seen, a pre-screening, to find out by asking some simple questions. I think and believe that training members of the faith communities throughout our country in SBIRT is also a wonderful idea and something I'm passionate about and committed to pursuing. Following pre-screening is a full screen for those with a positive pre-screen result. And then brief intervention for those who are scoring over the cutoff point. Brief treatment is for those who have moderate risk or high risk, or who would benefit from ongoing targeted interventions and are willing to engage in that process. And then, of course, traditional treatment is for those who are symptomatic or dependent and are willing to engage. I'm happy to report that there exists a SBIRT Faith and Spirituality Integrated Network. This is based on the work of Dr. Rachel Castaneda, who is an associate professor of psychology at Azusa Pacific University out in California. She received a grant from SAMHSA and is working with 8 faith-based universities in California to help train students in medicine, nursing, counseling, social work, pastoral kinds of ministry, so that they have an understanding of the importance of SBIRT as it relates to faith and spirituality. I would encourage you to connect with SBIRT and Faith and Spirituality organization, their network, by their website. In terms of early intervention, it's so important. In the core of recovery, it's personal transformation. Dr. Howard Kleinbell says this, and I quote, "The ultimate goal is to empower persons to grow, to empower them to grow toward their God-given potential for full personhood, for constructive relationships, for joyful spirituality and productive living, including service to a needy world." Sounds a little bit like the 12th step. In the Mental Health First Aid, in the first edition, it says this, and I quote, "It is easier for someone to recover from a problem, substance use problem, if detected and treated early, rather than after they become dependent on the substance. Early intervention will prevent many of the long-term ill effects on a person's physical health, social relationships, educational progress, financial status, and job perspectives, as well as help them to avoid serious problems with the law." So you might be finding yourself asking this question: what can I do to help? Again, Dr. Kleinbell encourages us that the heart of all effective counseling or people helping is a relationship that is characterized by warmth, genuineness, acceptance, caring, and trust. These kinds of qualities of relating are described in psychological language as therapeutic and in religious language as redemptive. His point is that a relationship without those kinds of things is really ineffective in facilitating either healing or growth for people. So what if someone needs help and they come and they talk to you as a faith community leader or people helper in general? The most important thing I would tell you is to know the resources in your community. As I said, we partnered with lots of organizations, and the cost to us was mostly our compassion and our time. There was very little financial outlay for us to be involved with those community organizations. So make sure that the members of your faith community know where to go for help. Ask them to reach out and talk with someone that they feel safe with. A trusted friend, a family member, a chaplain, a pastor, or a faith community leader, such as yourself. Refer them to their primary care physician or a counselor or therapist. That's why it's so important to know the resources in your community, as well as encourage participation in a mutual help group, such as Celebrate Recovery, for ongoing support. Well, I appreciate all of you who are with us today and encourage you to connect with us for further assistance. You see, I've got a couple of email addresses there that you can connect with me. Thank you so much for listening and sharing in this webinar today. And I'll turn it back over to you now, Heidi.
Thank you, Dr. Hoffman. I know you condensed a tremendous amount of information in that short amount of time, so thank you. It was really packed. And I know I had two very key takeaways. One is know your resources in your community. There is so much there. So if you really just want someone's coming to you, know how to connect them to what's already available in your community. And also the value of partnerships. Throughout your whole presentation, I could just see how both the Vineyard and other communities that you'd worked in were just reaching out to existing partnerships, existing resources, and rather than investing and creating new, that there were opportunities just in the community to partner and raise the capacity of the congregation. So thank you. Thank you for that. And now as we're moving along in time, I'm going to turn the microphone over to Monty Burks, who is now our Director of Faith-Based Initiatives for the Tennessee Department of Mental Health and Substance Abuse Services. Monty, are you ready?
I'm ready.
All right, handing it over to you.
Yes, well, good midday to everyone, and I want to thank you all for tuning in today to listen to us talk about what we're doing with our faith-based communities across the country. My name is Monty Burks. I'm with the Tennessee Department of Mental Health and Substance Abuse Services. Just a side note, it took me about 4 years to be able to say that in one breath without feigning, because it's such a long title. But a little bit of background about myself. I'm also in long-term recovery from substance abuse addiction. One of the reasons that I really took a passionate approach to working in this particular position is because when I first embarked on my journey to find my sobriety, it was an introduction to a faith community that had a step study, and I was really unfamiliar. It was 18 and a half years ago. I was really unfamiliar with what exactly a step study was and how to access a community of people that could help me. Now, obviously, I needed more than a step study. I needed to go into treatment. But what happened was that initial access point of being introduced to a step study from someone in the faith community opened the door for me to better understand myself and to go into a residential treatment program and get help. So now I'm in the position that I'm in now as the director of faith-based initiatives and special projects with my department. So I understand the powerful impact that our faith community has on individuals that are in recovery. So as we move into our slides, let me see if I can move here. So what is the Tennessee Community Faith-Based Initiative? The Tennessee Community Faith-Based Initiative was designed to connect our faith-based community with our prevention coalitions, which I will talk about shortly, our recovery courts, treatment programs, jail and prison programs, recovery programs, and Lifeline peers around the state to increase access to resources and ultimately become a resource. One of the things that we're really trying to promote amongst our faith community, because they're so large in our state, is to become the resource that they don't or didn't have when they needed it. And trying to supply whatever means we can through educational, informational resources to help them build that capacity. And the second part is our congregations that are willing to follow a best practice model, which we will cover, will be recognized through our state as certified recovery congregations. We recognize congregations across the state that follow this best practice model, and we like to link them together to build a conglomerate, a network that encompasses our 95 county reach. And what that means and what that does is it puts visibility on the recovery community, and it opens the door to more access points to individuals who need or are seeking help. So what is this best practice model? One, congregations who provide spiritual or pastoral support according to their congregational belief system. We all know that you can't go into an institution that's older than the institution that you work in and try to dictate or mandate how or what type of support to provide. The faith-based community in our state is our oldest institution, and we want to be respective of spiritual and pastoral support according to whatever their belief system is, whatever the denomination is. And one of the real cool things that has happened is our pastors they're evolving and reaching out to their congregation and letting people that are in recovery come up and have during recovery month, and as well as other times during the month, come up and provide their background and their training and their expertise and how the faith community connected them and how they can be a connecting point as well. Two, view addiction as a treatable disease by its definition. We want to work with our congregations to understand the addicted brain, the pathology of the brain, the prefrontal cortex, cognitive impairment. We have to move beyond the language of moral failing when dealing with people who need help. We obviously know that labeling causes people to not want to come to us as a religious or faith community to find help. So we want to break down those barriers. We all know that one of the first barriers to getting people into treatment and or recovery support is language used associated with people who suffer from addiction or have mental health issues. Number three, embrace and support people in recovery and walk with them on their journey. One of the most powerful tools that we have as a faith community is fellowshipping with people. That's one of the most powerful pieces that we have in the pews of our sanctuaries is large groups of people that are ready to meet people where they are. Fellowship with people who look different, who sound different, who smell different, that are from different socioeconomic statuses. We all know that addiction doesn't care how rich or how not so rich you are, or who your cousin is, or what kind of car your family drives. We want to be able to embrace people and work with people just as they are as they come in. 4, disseminate recovery information. Our department and our Project Lifeline peers, which I will again cover in some of the subsequent slides, get that information out in our congregations. And what we found through working with, I come from the faith community. I was raised in the faith community. I have a real diverse religious background. And I know that sometimes people don't necessarily always get everything that the pastor or leadership says on a Sunday morning. But if you have available recovery information that you can put on a bulletin board or on a table or a kiosk or hand it out with programs as people come in, we know that that's still another access point or a way to get people to access the resources in their community. And number 5, host or refer individuals to recovery support groups. Again, we're looking to get people help however that means. In Tennessee, we're the buckle of the Bible Belt. We have congregations on every corner. Some of them have 3 to 13 people that attend on an average Sunday meeting. We know that they're not going to be the prime target of having a Celebrate Recovery meeting or an AA or NA fellowship. But we want them to know what resources are in their community and connect them with other congregations that have recovery support meetings. We have congregations that have transportation to and from meetings, that have child care, that have feeding ministries, and we're trying to connect everybody as one body so we can get people access to those meetings. So here's the faith-based institution information from our state. In Tennessee, across all 95 counties, we have over 11,500 congregations. We rank 10th in the United States for number of congregations per people. That's a large, powerful demographic. We have 3 things in every one of our counties in Tennessee, and that is a jail, a health department, and an institution of faith. And when people are looking for help or need help, they somehow end up transcending all 3 at some point, trying to figure out where they need to go. So what we want to do is utilize, galvanize that 11,542 base to have an individual that's that ambassador of goodwill, that ambassador that's trained on addiction, recovery, mental health, access points. A person doesn't have to be in recovery to be able to tell someone where a recovery meeting is, and vice versa. The state's population is 6.6 million people. Over 3.5 million people in our state identify with some type of faith. That's over 50% of our state's population. That's a large and powerful number when we're looking at how we're going to get in front of addiction issues as they come through our state. So the number of Tennesseans, now these are just some other statistics. I want to do a large correlate to show you the power that we have in the pews of our sanctuaries in our state and how we've utilized that. In 2016 in Tennessee, there were 1,110 suicides. That was 16.7 per 100,000 people. The number of overdose deaths, all drug overdose deaths, was 1,631. And the number of people needing but not receiving treatment for illicit drug use, alcohol use, and abuse of or dependence on opioids other than heroin was 432,000 Tennesseans. And here's where our faith community's these numbers are powerful. There are over 3,000 people of faith per one person who committed suicide in 2016 in Tennessee. There are over 2,000 people of faith per one person who died of an overdose in 2016 in Tennessee. And there are 8.2 people of faith per one person who needed but did not receive treatment in Tennessee in 2016. And I have a good friend of mine, Dave Hodges, that says the point 2 is 2 more arms that we could wrap around somebody else to give them some type of support. We all know that recovery support is much more than a 12-step group. It could be something as simple as giving someone a hug and introducing them to someone at a group that can possibly give them an access point to get them into treatment. So utilizing the Continuum of Care, we developed a method, a model to be able to promote prevention, treatment, and recovery, and to get our communities involved, get the champions in our communities involved and kind of push out and change the narrative around substance abuse and mental health issues. So 1, we use the Lifeline Peer Project for promotion. The Lifeline Peer Project was established to reduce stigma related to the disease of addiction and increase community support for policies that provide for treatment and recovery services. The project approaches include establishment of evidence-based and recovery programs, educational presentations for civic groups, faith-based organizations, and community leaders to increase the understanding of the disease of addiction and support for recovery strategies, facilitate access to treatment and recovery support amongst diverse community. As today, we have 10 Lifeline peer coordinators across the state of Tennessee. Starting in the next 30 days, we will have another 11 added, and their primary focus will be connecting communities with people from the ERs and the EDs that have come through with either overdose issues or addictive issues from the hospitals. So what the Lifeline Peer Project has done in the last 3 years is they provided over 2,500 recovery trainings, referred over 1,700 people into treatment, and started over 300 new recovery support meetings across our state. And what they're basically doing is they're going out and utilizing their personal stories. Each one of the Lifeline cohort are openly people that are in recovery. They use their recovery story, their past, their trials, their tribulations, and the power that they've used to overcome their addictions to be able to connect with the community on an organic level and be able to pull people into or get people access to resources. So the prevention community, the community connection, utilizing our preventions. Tennessee has 52 substance abuse prevention coalitions around our state. Our coalitions bring together people and organizations and leverage resources to decrease their community's substance abuse related problems. Our coalitions have deep connections to the local community and serve as catalysts to reduce local substance use and abuse rates. The coalitions are boots on the ground that have deep tentacles and roots in our communities. So we wanted to, as utilizing that continuum of care, reach out to them to get the conversation started. And our prevention, most people on here understand how our prevention coalitions work. There are 12 sectors. What we want to work with specifically is our religious sector to help our this encompasses everyone, but we're trying to do a much more line approach with our religious communities because, one, our religious communities cover more ground in our state than any other organization or demographic that we have. Faith-based prevention recovery support forums is what the concept that we've come up with. So utilizing these prevention coalitions as driving mechanisms, we've had recovery forums set up across the state with 6 goals. 1, understand recovery. Go into our faith communities and make sure they understand the difference between treatment and recovery. 2, access community resources. Invite our state resources, community resources, inside, outside, profit, nonprofit, community-based, it doesn't matter. Get everybody in the same room to have a candid conversation. Creating access points sometimes is as simple as creating breaking down a language barrier between communities. 3, build stronger community partnerships. People that show up to these community forums are willing to work. So we like to connect them with each other through the forums, and not just in their area, connect them with other groups like themselves statewide. 4, connect community with the Lifeline Peer Project. Our Lifeline Peer Project is an integral part of how we're working to get people access to treatment. So having them at these forums as a resource, or at least someone just to talk to so a family can understand how to navigate the system. 5, pull in congregations as partners. The largest resource we have in the volunteer states are our congregation. And it's an untapped resource. Our goal is to have all 11,542 congregations at some point have some type of addiction recovery ministry, mental health ministry to access outside resources and, again, become that resource that they don't have. And 6, networking congregations in order to share organic resources. So the outcome, the faith communities have partnered to represent their sector. So at just that one sector, they've broken that sector down and become faith-based recovery coalitions. They're working side by side with our prevention coalitions as an arm of the prevention coalitions to increase outreach and impact on their respective communities. We have 9 faith-based recovery coalitions that are formed across our state, and they're not only doing work in their communities, they're actually utilizing each other as a contact point and base to share educational activities. So our recovery courts are special courts willing to handle cases involving substance abuse, abusing offenders through comprehensive supervision, drug testing, treatment, services, and immediate sanctions and incentives. We have almost 70 courts broken down as follows: adult, veteran, mental health, juvenile, and family. With respect, our Lifeline goes in and works with our recovery court, and this is all going, I'm going to show you guys how this all comes to play with our faith community being right in the center. Lifeline meets with recovery courts and assess recovery courts' needs in their respective regions. They introduce the faith community and the faith-based partners to the recovery courts as a resource trained to follow and work with recovery courts support model. Lifeline has been trained to facilitate and or find community partners to help facilitate meetings, any type of meetings needed for recovery court. Lifeline can find the faith-based organizations to host those meetings. Now, an example of these meetings is not just AA or NA, it's clothing, food, employment, housing, resources for individuals who are ready that have hit the point where they're ready for change. They need those resources. And these are just some of the types of resources that our Lifeline connects our community together with. And other types of recovery support services that our congregations are using. Our congregations are, because of the robust size in Tennessee, they are the employment community. They do have access to helping individuals who've had bumps and bruises along their path, getting access to a job, employment services, job training, case management, self-support groups, relapse prevention, spiritual and faith-based support, housing assistance, education, child care. We all know that when individuals go to meetings and to treatment and IOP, they need child care so they can go, because they can't always take the kids with them. So the finishing pieces, what we've done is been able to connect our faith community to our licensed treatment programs across the state. We've connected our faith community to our recovery support programs and resources across the state, and our congregations identifying champions to become peer recovery specialists. And that's for another presentation that hopefully Heidi will invite me to. Our congregations getting people trained to become CPRS and certified peer recovery specialists has been a great resource for them as well as other people in the community. And here are our results. We have over 281 certified recovery congregations that follow that best practice model, and they connect their congregations with treatment and recovery resources. We have over 50 working to become certified, and we provided 86 educational forums in 80 out of our 95 counties. And what we've been able to do is link up the counties with each other. We have some very remote rural parts of Tennessee that don't have a lot of resources, but when you have 3, 4, 5, and 6 counties that work together, and even one area we have 8 counties that have built a Northeast Tennessee faith-based recovery support network. They utilize each other as a resource until they can find other resources so they can be more of a community-based or something to transition someone into something else. Now, that is the end of my slides and my presentation, and my contact information is here, and I thank you all for listening in, and I'm going to look forward to answering some of your questions.
Thank you, Monty. I swear your phone must be on fire. You talk so fast. That was fantastic. So you do have a couple minutes left, and I want to, because what's popping in my head, and maybe for our audience today as well, is what does the certification look like? So a congregation, because we're working with folks with congregations, they're identifying, or perhaps someone is self-identified to be in recovery and say, I want to use my experience and the wisdom that I've gained through my own experience to help others. That person is identified in a congregation. Take us through, what does the certification look like? What are the skills that they gain, or what does that look like? How do you take them to be someone who's actually walking with someone with through drug court and all those wonderful opportunities that they have there? So just take us through that a little bit.
Okay, so what we do is when a congregation, we connect and are able to network with congregations that are forums. They will show interest in becoming a certified recovery congregation. Some of them already have recovery support meetings, and some of them don't. The ones that don't, we try to help them understand the model of evidence-based treatment and recovery and how they can be influential and impactful in a person's evidence-based strategy to help them find their sobriety. And we will educate champions in the congregation through inviting them through mental health training, suicide training, addiction versus dependent, the addicted brain, treatment versus recovery. That champion becomes the champion for that congregation to be the access point for people in that congregation to get other resources outside of what they can provide. There's a six-question questionnaire that's on our department website. We capture that information, and then when that information is captured, if the congregation needs help or TA to be able to strengthen their capacity, Project Lifeline goes into the congregation and helps them figure out through needs assessments, simple questionnaires, figure out what the congregation needs, what their capacity is, and how willing they are to work with different individuals. Obviously, every congregation that signs up that wants to become a recovery congregation doesn't necessarily have the capacity, or sometimes they don't want to move outside of denominational difference, but that still doesn't mean they can't be a resource in their community and identify a champion to be the resource specifically geared toward or for them.
Right. Okay, good. And I'm glad you brought up your website, because I know that's that you have lots of, it's a very transparent website and lots of resources to share. We've gotten a couple questions about, people holding events or doing some, conversations in their own communities. I would definitively commend that the website of the Faith-Based Initiative at the Department of Mental Health and Substance Abuse Services at Tennessee for many of those resources. And also, I wanted, Dr. Hoffman, could you, if a community is interested in going through actually something like this SBIRT, the screening, brief intervention, and referral to treatment public health process, how would they even engage that kind of, who would they have to seek out to get that kind of level of training or capacity building in their community?
Well, every state is a little bit different. Here in Ohio, it's the Ohio Department of Mental Health and Addiction Services, MHAS. If you contact them, you can go on their website and actually do a search on the website for SBIRT training and can find different trainings that are available. Of course, Dr. Castaneda, you can go to their website and find, they actually have training available online, which is a great way for people to access training. So if they simply go to the SBIRTfaithandspirituality.org website, all the training components are listed there, and then you can work your way through and receive that training that way if there's not a training available to you locally.
Fantastic. And that was the slide. We had that address on that slide earlier. Well, I think what I really appreciate in both your presentations is that no matter where a community is, they can participate in the continuum of the recovery journey, no matter where someone is. And so that's so hopeful that folks can do minimally that to just make it prominent in your community. Where do these resources exist? I had in my mind that I was going to put in my faith community that image of the staircase. You don't have to see the whole staircase. Just take the first step and actually list under that where our local mutual aid support groups or other services are. Even the SAMHSA hotline, access to the SAMHSA hotline for help and access to treatment. And we also have those listed in our toolkit. Hey, listen. So there's one question we have that came in from a couple of folks, and Ben has synthesized it to say that folks are still thinking that in order for community, that idea of congregational readiness, when a community is actually ready to support those who are experience substance use disorders or needing help, a connection to support services, what does a supportive community look like? That question of how can we reduce prejudice that is felt by individuals who are seeking or in recovery. So in your mind, if you could describe in the time we have left today, what does a supportive community look like? Perhaps I'll have Dr. Hoffman, you start with that, and we'll have Monty follow you.
As I think about a supportive community, I think about a community that embraces and shows love and care and concern and compassion for any individual, regardless of what their struggle is. I think that is one of the first and foremost things that I consider. I think another thing is being able then to provide access to groups where people can get help. And there are many communities that perhaps don't have a mutual help group that is available. So exploring ways, how could we use our faith community resources, our facility, our building to host a group so that people have a way of connecting. Finding out the resources that are in the community is just so important. I have a resource directory that I built of just various treatment options and counselors and so forth and groups all over not only the Dayton Metroplex, but our whole state, so that we can help connect people. And I think that's another thing. Reducing that stigma is so important just by education and realizing that we all struggle. A great book that can help with that is by a psychiatrist by the name of Gerald May, entitled Addiction and Grace. And I think it's a wonderful volume to begin to read and just educate ourselves and to help us to take another step forward.
Thank you, and thank you for that reference to that book. Monty, would you like to say what you think? What does a supportive community look like?
Oh man, Dr. Hoffman hit it right on the head. I appreciate you, man. Supportive, willing to work with people and meet them where they're at. You want a supportive community to become a recovery community. That means encompassing and working with everybody, no matter what the issue is. Substance abuse issues coupled with mental health issues, coupled with lifestyle choices. Yeah, those are things that come up. So having people willing to meet people where they are. Our faith should allow us to work with people regardless if they believe the same thing we do or not. And working with our communities, we're starting to see that our people are ready to be that boots on the ground to embrace individuals regardless of who they are, open to education outside of whatever their religious denomination, background, or community suggests. Sometimes there are religious ties and denominational differences that keep people from working together or wanting to look at other things outside of what they're used to. When we provided a community-based addicted brain forum, and we did it in one of our rural areas, and we had 77 pastors out of 110 people, 77 clergy from 7 or 8 counties came to get a better understanding of what the addicted brain was, how it worked, and how they could fellowship with people long enough to help them find themselves. And that's what a recovery community looks like. Getting our clergy, our leaders to understand that if you don't have a meeting, it's okay to send someone else to another meeting, because you don't lose a member, you gain an ambassador. And that's the power that we have.
Wow, well said, both of you. Thank you so much for that. Hey, listen, before we have a really good question that came up. So when we're looking at building the capacity of communities, congregations and communities, and educating about the nature of addiction as a chronic condition, and all the dynamics around it being a brain disease is something that's actually a treatable disease, how are you partnering, or how are you connecting clinical or healthcare providers or treatment providers to congregations and those partnerships? What would you recommend to people about how to connect with the healthcare system or the provider system in their community?
Which one of us going? I can go ahead.
Go ahead, Monty.
Thank you, sir. one of the reasons that we started doing those community-based forums is so we could have our healthcare providers there, so the congregations could connect with them themselves. We wanted to be able to put everyone together and let them understand. When you meet someone, it's different than an email or a phone call. It's different than accessing someone on the website. There can be wonderful relationships built with a handshake that can get people to learn how to access each other for resources. And that's how we've been effective. Is our treatment providers, our healthcare providers have been coming to the recovery support meetings, and then they have themselves started to identify, as a progeny of this initiative, they started to identify people in their agencies to be the conduit or the connector with the faith community. And that's been something that's been an amazing and wonderful transition, because it creates a relationship between our clergy and those organizations that hadn't been there in the past.
The thing I would add to that, and I think that's an excellent thing to actually have folks connecting in-house, if you will. Another great resource is the American Society of Addiction Medicine. There are physicians who are trained in addiction medicine. And I would encourage every faith community leader to find out who those individuals are in their communities, or as close to their communities as possible, to find medical personnel who are trained in addiction medicine who could serve as a tremendous resource for you.
Absolutely.
Well, I think I can't thank you both enough. This has been such a substantive conversation, and thank you for both of your thoughts on that Q&A. Friends, we recognize that the opioid epidemic is in many ways a crisis of hope. So please consider sharing hopeful stories that you have experienced or witnessed emerging from your community online as part of the new crisisnextdoor.gov initiative, and help cut through this prejudice that is too often associated with substance use disorders while spreading the good news of hope and recovery. Details are on the slide here, or you can visit crisisnextdoor.gov. And also, please note we will be sending a link to the recording of today's webinar in the follow-up email to everyone who has registered. I'd like to personally thank our speakers today, Kevin Hoffman of Ohio's Three Oaks Center and Monty Burks, Tennessee Department of Mental Health and Substance Abuse Services. Thank you for taking the time to share your stories, insights, and experiences with faith and community leaders in both Ohio and West Virginia. And thank you to each of you out there who have taken the time out of your very busy day to learn more how to bring hope and healing to your community. So stay in touch. If you're not already on our mailing list, please send us a note at partnerships@hhs.gov. Thank you for your time today. Thank you, Kevin and Monty.
You're welcome.
Welcome.
Bet.
Thank you.
Okay, so we'll hear more from everyone later. And stay tuned, folks out there, for our follow-up email. Have a wonderful afternoon, and thanks to each and every one of you.